Hi, everyone. My name is Mary Cochran Abraham, and I'm honored to be asked to speak at your Lunch and Learn. And I am a nurse practitioner at Kaiser Walnut Creek in the Department of Neurology. And there I work with our movement disorder specialists. And most of what I do is program deep brain stimulators. And I do some also initial evaluations prior to deep brain stimulation surgery. And I don't know if I mentioned, I'm a gerontology nurse practitioner. So my specialty is older adults. And should I share my screen? You're muted.
Yeah. Yes, you can start to share your screen.
Okay. Into the PowerPoint. So Rick, do you see?
We see everything. Your slides on the left-hand side and the highlighted slide in the main part of the screen. And
okay. So I'm doing
work just fine.
I'm doing F Shift 5, and it doesn't seem to go in to.
Okay, well then what I would do is slideshow, click on slideshow.
Mm-hmm. From the beginning.
Yeah.
Okay. All right, there we go. Okay, well, let's hope the technology works for this presentation. Is that showing just the current slide now?
It shows an outline and the current slide, and that's fine. Why don't we just...
Yeah, so we're going to go ahead. So apparently what it shows you is what the next slide will be. So it's giving you a little preview. So that's just the introductory slide. And then this is just an outline of our talk today. I'm going to talk a little bit about the history of neurostimulation, what targets we're using for Parkinson's disease, and some of the benefits and limitations of deep brain stimulation. I'm going to talk a little bit about our program at Kaiser and very briefly the surgical procedure. And then I will go into the programming of deep brain stimulation and a little bit about the future, where we're headed. So not everybody maybe knows what deep brain stimulation is, and it's DBS for short. So DBS is a method of delivering electrical current to areas of the brain which can help with Parkinson's disease symptoms and with other neurologic symptoms. So it involves implanting electrodes in specific areas of the brain and connecting those electrodes to a battery implanted in the chest. And that battery is known as the implanted or implantable pulse generator. We call it the IPG. So the electrodes produce electrical impulses that regulate abnormal brain signals or impulses that can affect certain cells or even chemicals in the brain. So this is a wild idea. We're sticking electrodes in people's brains and sending electricity. It's kind of an amazing idea, but actually, the first people to use electricity for medical purposes were in ancient times. So even starting in ancient times, people were using electricity. And the guy there in the middle, Scribonius Largus, he was a Greek physician in ancient Rome, and he wrote a whole compendium of medical procedures and treatments. And that was written in 46 AD, actually. So he described in there the use of the electric torpedo fish to treat headaches and gout and other ailments. So that was 46 AD. But there's evidence that even in ancient Egypt, long before 46 AD, people were using electricity to treat different ailments. So it wasn't entirely new. So fast forwarding to more modern times, I have a timeline of developments in deep brain stimulation. And so in the early 1800s and 1900s, people were already using electrical stim to map areas of the brain. And that included two scientists, Horsley and Clark. And in 1909, they used the first skull-mounted stereotactic frame, and it used external landmarks to guide slender probes. They were working on monkeys, I think, at that time. So these were animal studies. But they were learning about areas of the brain using this apparatus. And in the 1930s, clinicians started using electricity delivered through probes, which are electrodes, to explore the function of various areas in the brain and to map these areas. And in doing this, they identified targets for ablative surgeries, ablative procedures, which they figured out when they destroyed little tiny areas, specific areas in the brain, they were able to stop some of the symptoms people have with Parkinson's and other neurologic problems. So then in the early 1940s, the mortality rate from neurosurgery was, as you can imagine, it was very high, 40%. And this was due to problems with bleeding, with anesthesia problems, and also inaccurate targeting. And so now, along in 1948, along came this guy, Lars Lesko, and he is this guy here. And he developed the arc-centered stereotactic frame, which you see in his picture. And that's the arc-centered stereotactic frame. So that frame allowed much more precise targeting for neurologic procedures. So he was able to attach an X-ray tube to his frame and target very specific areas. And basically it was the precursor to the gamma knife, which is still used to perform different ablative surgeries for Parkinson's disease. So then I just mentioned at the bottom there in 1960, there was a team with Chardak, and they developed the first implantable pacemaker. And that allowed for the whole DBS system to be implantable, 100% implantable. Now in 1963, this scientist, Natalia Petrovna Pekareva, she was at the Institute of Motor Disorders, Experimental Medicine in Leningrad. She actually published a study in 1963 reporting on the use of multiple electrodes that were implanted in subcortical structures for the treatment of movement problems in Parkinson's disease. She had excellent results. Her paper was not widely read because it was published in Russian. So there continued to be quite a lot of development in that area of deep brain stimulation and the use of electrodes for treating neurologic problems. But then in 1967, we had the development of levodopa. And we learned that levodopa, which is Sinemet, carbidopa-levodopa, can dramatically improve and relieve symptoms of Parkinson's. Now, with the development of levodopa, all the research and work in the neurosurgical area really came to a stop. And for a while, there was a lull and not a lot of work in that area until people started to learn the limitations of the Sinemet. And so once they started to learn about that, then interest picked up again in the area of deep brain stimulation. We had, first of all, the use of deep brain stimulation in the thalamus in 1991 by two different groups, and they were able to really reduce tremor in essential tremor. Then in 1997 was the first FDA approval of Medtronic's system for treating essential tremor with stimulation to the thalamus. So it moved from the area of research to actual treatment of patients with a commercially available system. In 2002, this system was approved for targeting the subthalamic nucleus and the globus pallidus. These are two structures in the brain, and they are the targets for Parkinson's disease. And so just to give an idea of where are these places in the brain, down in the lower left, you see the whole brain down here. And this area encircled by the caudate, the purple structure here, this is the deep brain. It's the basal ganglia. Within this area are the two targets for Parkinson's disease, the subthalamic nucleus, which is this tiny little bit of blue right here, and then the internal globus pallidus, which is this little bit of green over here. And the next slide will show this a little bit better. So these are the two targets for Parkinson's disease. So on the left, that's the GPI, we call it GPI for short, the globus pallidus internal. And this is a good target. Actually, let me just first say that the STN and the GPI are excellent targets and really pretty much equal in their ability to treat Parkinson's disease symptoms. So the GPI has a slight advantage for people with any cognitive issues or psychological issues. And when you target the GPI, you have some benefit on dyskinesia, but you cannot reduce medication use. When we target GPI, we do not expect people to lower their Sinemet medications. Also, some gait problems that respond to Sinemet are slightly better treated with the GPI. Now, the other thing about these two structures is you can see in this side, the STN here in yellow is a much smaller structure. It is about 150 cubic millimeters, and the GPI is about 450 cubic millimeters, so it's a little bit larger. The STN has the advantage that people will be able to wean down some Parkinson meds, usually about 30 to 50%. And that allows for improvement in dyskinesia, which is caused by the medication. And there's also a slight benefit for slowed movements, which are bradykinesia, with the STN as a target. And because the STN is smaller, it takes a little bit less current, less electrical stim, so the batteries last longer when you are targeting the STN. Okay, so now in terms of the benefits of DBS for Parkinson's disease, what we generally expect and what we see is improvement in tremor, rigidity, and bradykinesia, which is slowed movements. You can have improvement in dyskinesia by being able to reduce meds. And then you do have improvement in on-off fluctuations. So that on-off, you might know that's where your medicine suddenly wears off. You're suddenly off, your medicine's not due for another hour. Those are on-off fluctuations that people have with Parkinson's. Now, the limitations for deep brain stimulation. Number one, it does not cure Parkinson's disease. And it does not stop the progression. So this is similar to Sinemet, where it does not cure or stop progression of the disease. And it does not eliminate the need for medication. You're not going to throw your medicine out with DBS. You'll still need some medicine, most likely, but it can reduce the amount of medicine that you need. And then not all symptoms are going to be treated. We cannot really usually help problems with balance. Generally, problems with gait, which is walking, are not improved unless they are improved with your Sinemet, your levodopa. So if your walking is improving with levodopa, it may improve with DBS. But if it doesn't improve with levodopa, then it probably won't improve with DBS. Problems with speech that people have with Parkinson's are definitely not improved with deep brain stimulation. I always tell patients, we are not going to help speech, but we can make it worse. We can make that as a negative part of deep brain stimulation. It has that ability to actually make speech worse. And then freezing of gait is not helped with deep brain stimulation. And that's the problem where you are approaching a chair or the curb and you just kind of start to freeze. You have those little stutter steps, and that's freezing of gait. That doesn't usually get better with deep brain stimulation. Right, I wanted to talk a little bit about our program at Kaiser. Our program is called the Northern California Comprehensive Movement Disorders Program. Usually I call it the Neuroscience Team for short. So our team has been in existence since 1996, and we've been bringing neurosurgical treatments to our members with movement disorders. And the most commonly treated disorders are Parkinson's disease, essential tremor, and dystonia. So we are an interdisciplinary team, which means that we have several different disciplines on the team. Our team covers the whole Northern California Kaiser region. So that is basically, we have members out in Sacramento, the North Bay, the Diablo service area, San Francisco, the Peninsula, and San Leandro, and down into the South Bay. That's where our team members are. So our team consists of movement disorder neurologists, neurosurgeons, of course, biophysicists who are involved with the surgical procedure, nurse practitioners like myself. There are 3 of us on the regional team, physician assistants who are helping the neurosurgeons during surgery, the neuropsychologists who provide the pre-evaluation neuropsych testing, and then our program assistants kind of keep everything together administratively. So that is our neuroscience team at Kaiser. And our team is involved in the care of our patients throughout the selection process and the surgery, and then after that with all of the programming of deep brain stimulators. Now, not every patient is appropriate for deep brain stimulation, and here are the selection criteria for our patients. So generally, people who have the off-on fluctuations and the unpredictable offs, dyskinesia, these are good candidates for deep brain stimulation as long as they respond to Cinemet. The one caveat is that sometimes people have tremor with Parkinson's that just doesn't seem to respond to levodopa. And that tremor does respond to deep brain stimulation. So number 1, we're looking for a good response to levodopa, because I always tell patients that DBS, you can expect basically your best time on medication is what you can expect from deep brain stimulation. Candidates should be less than 80 years old because older adults are not, older than 80, probably more of a risk for surgery. And of course, there is some variation. So this is not a hard stop, but generally candidates are more appropriate when they're under 80 years old. We don't want candidates to have a lot of serious other medical problems like severe heart disease or lung disease, because those increase our surgical risk. We don't want people who have a lot of brain atrophy or other structural issues in the brain that are in the way of targeting with the electrodes. And then people with dementia are not appropriate candidates, or people with severe psychiatric illnesses such as schizophrenia, severe disabling anxiety, and things like that. Those people would not be good candidates. And so in our program, the steps for potential candidates, there's basically 3 evaluations people have. They have the off-med, on-med videotaping, which is part of what I do for the team. And so there we are using the UPDRS, that's the United Parkinson Disease Rating Scale, which is a certain set of movements that patients go through on video, and that scale quantifies people's movements, and it helps us quantify the response people have to medicine. So people come in, I videotape them going through the movements, then they take their medicine, and about an hour later, when the medicine is working, I videotape again, and we see the difference and quantify the difference between having no medicine and having medicine. They also go through the neuropsychological evaluation, and they have a brain MRI. And then all of that data is reviewed by our neuroscience team at our meetings. We meet 8 times a year, and it's at those meetings that we approve candidates for surgery, depending on the results of the data. And the nice thing about our team is that we have people from all disciplines. So any person on the team can say, you know, I'm worried about this person being successful with deep brain stimulation. So it's not just the surgeon, not just the neurologist, but all of us actually together decide on our candidates. And briefly about the surgery. So I have observed surgery. I've been in the OR, but I do not work in the OR, so I wouldn't be able to answer specific questions. But just generally, the surgical procedure, people have their hair shaved and the head frame applied at the beginning of the day of surgery. And the head frame, you can see, is the arc-centered stereotactic frame right here. You can see in our picture that frame that was developed in 1948 by Lars Lesko. And that's used for targeting, right? For placing the probe and targeting. So they get their head frame applied, then they have a head CT scan that's done for targeting purposes. Once the target path is determined, then the surgery starts. Incision is made, a small hole is made through the skull. It's about the size of a nickel. I can tell you, standing in the OR, you don't see anything of the surgical site unless you are directly over the shoulder of the surgeon. So it's a very, very small site. So through that hole in the skull, that is where we insert the thin probe, the microelectrode. And that electrode records brain signals, and it actually records the sound that brain cells make. And they use that sound to target the area in the brain, because unfortunately there's no big light or sign that says here's the STN or the GPI. When the surgeons are doing this, they are determining this target based on that imaging that's done, and then based on the sound that they hear when they put the electrode in. And then they send a little bit of current to the electrode, and the patient is awake. You can see down here on the lower picture, and we need the patient to be awake during surgery so that they can participate and they can move, and we can tell if the tremor is better, if the movement is faster, or if there's less rigidity. So they're awake in order to participate, to help us know that we have the electrode in the right place. And then once we have the electrode in the right place, the probe, actually that probe is withdrawn, and the actual electrode that's implanted is implanted in that location. And then on a final surgery, the incisions are closed, patient is put under general anesthesia, and the wires are tunneled to the chest and the battery is inserted. Now, our surgeries for Parkinson patients typically are going to have both sides done. And these are done one at a time. And there is a gap of 2 weeks to a few months between those two surgeries. If the plan is for 2 weeks between the surgeries, the battery will be implanted on the second surgery after the second electrode is implanted. If there will be a gap of a few months, then the battery will be implanted during that first surgery. Okay, so some of the possible complications, which the first one is not mentioned here, and that is the complication of death. Death is always a possibility for every surgery, especially with general anesthesia. The risk of death from a surgery is much less than 1%. None of our patients have ever died of our surgeries. Stroke and seizure are a possibility that is very rare, 1 to 2% chance of stroke or seizure. There's a risk of infection with every surgery, with any incision. That would usually occur at the surgical sites, and it would be treated with antibiotics. Now, it's possible, but extremely rare that it would happen, that there could be an infection, a deeper infection that required removing the electrodes and the wires. Personally, I've never seen that happen for any of our patients. So beyond the surgery, there's a risk of a change in mood or thinking. So part of the reason we want to make sure people don't have dementia before becoming candidates is that inserting electrodes in the brain can have a cognitive impact. Generally, it's very small, but we don't want to, take somebody who already is struggling in that area. So there can be changes to your balance and walking that may or may not improve over time. There can be effects on speech. And if those are caused by the electrical stimulation to the electrode, they can be reversed. And then rarely, there could be problems with the components, the actual hardware of the system. I've seen that happen only once. In the last few years, that patient was actually implanted at a different program, not at a Kaiser program, but we were able to remove the damaged hardware and put in functioning hardware for them. So those are the risks. All right, so about 2 weeks, say 2 to 4 weeks after the surgery, patient comes to see me or one of the other nurse practitioners or neurologists, and we do the initial interrogation of the DBS system. This is where we turn on the stimulation. It is not turned on for those first few weeks. And the reason we wait is there's a little bit of swelling in the brain, you can imagine, as a result of the surgery. And we want that swelling to completely subside before we do any programming. So at that first visit, we turn on the stimulator and I send current to each of these contacts. So you can see on this diagram, there are 4 contacts on the probe, on the electrode or the probe. And I send stimulation to each one separately. And in that first visit, I am looking for, is there a response, a positive response, a decrease in symptoms, and what level does that occur at? And then I usually look for how high can I go on the current before getting a side effect. And so the side effects that we see during programming are things like tingling that don't subside. There can be some slurred speech, so speech can be affected. There can be muscle pulling. So there you might just, and that these are all reversible. They're a result of the current, which can be reduced. And I'm just looking to see on each contact, what's my window? How wide is my therapeutic window on each contact? At the end of that first visit, I usually leave the person's stimulator on and I leave it at the contact that seems to give the best response. Now, each patient has their own controller. They have a patient controller that they have at home with them. And I set parameters within which they can adjust the current. So they're able to go up and down on the current based on those parameters. So at home, they're encouraged, if the symptom comes back, you can try going up very slowly. And I teach people how to do that and look for improvements to the symptoms. And it can take, I always tell people that it can take up to 6 months of visits to optimize the program for deep brain stimulation. Sometimes we can get a great response within the first few visits, probably most commonly we do. But sometimes it's a little more difficult and it can take several visits to optimize the settings. Now, we are controlling 3 parameters: the wavelength, the current, and something called the pulse width. So there's thousands and thousands of possible settings on a deep brain stimulator. But usually within the first few visits, we are starting to narrow in on a good setting. All right, so what can this whole thing do for patients? And in this next slide, I have a video of a person with tremor predominant Parkinson's disease. And they're going to turn on the stimulator and we can see the response to stimulation. So let's see if this runs.
Session. This is what it looks like without the medicine and the stimulator. And now we're just going to turn it on. I can get my fat fingers to hit the button. There we go. See how that feels. How you feel? Yeah, a lot better. Yeah. Excellent. Try.
Okay, so that is a pretty dramatic response to deep brain stimulation. And generally, we do see a great response with tremor. And tremor is, of course, the most noticeable improvement. So in terms of a video, we aren't going to be able to see the improvement in rigidity or improvement in slowness, as well as we can see the improvement with the tremor. Sorry, I'm just going to the next slide. Okay, so the latest development in deep brain stimulation is what we call directional neurostimulation. So the initial systems were this top diagram. This would be the initial Medtronic system. It's an electrode with 4 contacts on it. And this is a cross section looking down the electrode at a contact. So in the middle, this dark gray ring, that is our contact on the electrode. And it is producing a electrical field that's pretty much circular around that contact. So if you have a sweet spot, so this green area is an area that when stimulated, symptoms get better. And so you're stimulating this sweet spot with this electrical field, but unfortunately, over here, this red area, this is a part of the brain that's getting stimulated that's producing a side effect. So maybe a problem with speech or muscle cramping or some other side effect. So with a solid contact like this one, it is difficult to shape this electrical field such that we can stimulate just the part with the good response. So directional electrodes, are basically the bottom picture. So you see this one down here. The contact, this gray ring, is now split into three segments. And current can be sent to any of these segments individually. And this allows for steering of the current. So in the middle picture, they are steering the current 100% towards this segment that is at between 9 o'clock and 6 o'clock over here. And so that improves a little bit on the side effect area, but we can also turn that and basically steer the current to these other segments, and that is stimulating the area that's producing reduction in symptoms, and it is not stimulating that red area that was producing side effects. So that is directional neurostimulation. There are two companies that are producing systems with these segmented contacts. So that is Abbott, St. Jude, and Boston Scientific. And right now we are implanting pretty much all Boston Scientific in our program. And that's because the Abbott St. Jude doesn't have quite as much control of stimulation to these contacts individually. In Boston system, you can choose one or two, but in the Abbott system, you can choose one or two, but in Boston's, you can really shade the amount of current that you're sending to each of those a little more finely. So there's a little more directional ability with the Boston system. So basically, this helps whenever an electrode is not placed absolutely perfectly in a target. And our surgeons are pretty remarkable at their ability to place electrodes pretty perfectly in the target. But the STN is about the size of the top joint of your little finger, or about the area covered by the fingernail. This is a tiny area in the brain to hit with that electrode. They do a great job, but if there's slight variation, that's where the directional systems are really important in being able to focus our current. So that's the latest system that we are currently using. And then I wanted to talk a little bit about what's on the horizon for deep brain stimulation. And up at the top here, the brain sensing technology is actually being developed, or has been developed, by Medtronics. And this system with these electrodes, basically it's their battery, which is called Precept, their new battery. We have a few patients who now have this new battery implanted. And it allows the electrode at the end to sense and record the signals that the brain has over time. So it's actually able to sense these electric field potentials that are a result of the natural brain signals. And these fluctuate with medication. They fluctuate with stimulation. And in the future, they will be able to kind of close that loop so that stimulation can be automatically adjusted to different signals that the brain is giving off. And so that's the brain sensing technology. Right now, with our patients with the Precept battery, we're going to be able to collect data to see how these brain signals change with respect to medication, maybe be able to time medicines a little bit better. And a patient would be able to adjust their stimulation also based on that. So that's one thing on the horizon. Also on the horizon is incorporating a patient's brain imaging into the programmer and putting that together with a brain atlas. So such that on the programming screen, I would be able to see exactly where an electrode is in a particular patient's brain with respect to those targets that we are hoping to stimulate. Currently, a programming screen does not have any imaging from a patient on the screen. So currently, what we're doing is we're sending a stimulation to the contact and just looking based on response and determining the best optimum contacts that way. So it'd be nice to have an actual image of the patient's brain and be able to see where our electrode is. And then there are also advances in directional electrodes where there will be electrodes with multiple smaller contacts that allow stimulation at any level and would allow for finer targeting with the electrodes. So those are things that are on the horizon for deep brain stimulation. So on this slide, I'm including some resources, and these are websites that are on the Kaiser, that are from Kaiser, but are available to anybody. Anybody can go and look at these websites. There is a video there that talks about the surgery and people's experience with deep brain stimulation, and then also some educational videos that we always ask our patients who are candidates to look at on deep brain stimulation. So you can look at those websites and see what information there is for you. Okay, so that brings us to the end of the slides and the beginning of questions. And Rick will have to help me because I don't know if I can get out of my...
No, let me, let's say, end your slide presentation. Okay, I think I got that person. Marjan, you had a question?
Yes, I have a question. The part of the surgery when the patient is awake, doesn't that create pain? It's painful, right?
Of course, that's the thought, but actually no. Patients, they are using local anesthesia. The brain itself has no pain sensors, interestingly. So it's only the skin that would have any sense of pain. And a lot of brain surgeries are done with patients awake because we want to see what their response is. And because it's very easy to completely anesthetize the skin, and the brain doesn't need any anesthesia because it doesn't sense at all, actually. So people will hear the sound when they make the hole through the skull. You know, people might feel pressure and hear sound, but they don't feel pain.
Okay, thank you.
All right, next question from anyone who would like to ask.
I have a question.
Go ahead.
In addition to tremor, I have non-motor symptoms. Handwriting is horrible, can't read it, and I have trouble sleeping, which is directly related to Parkinson's. How does DBS affect those two symptoms?
Right. So I don't know about handwriting. It might get a little better. Generally, I would tell patients that the non-motor symptoms of Parkinson's, those are things like constipation, problems sleeping, problems with frequent urination. Some people have problems with low blood pressure. None of those are helped by deep brain stimulation.
Okay.
Now, that being said, I do have some patients who tell me that with DBS, they are sleeping better. So, you know, it's hard to tell if sleep is disturbed by tremor or by rigidity or slowness, then it may be improved by DBS. But I ahead of time, I would tell people, do not expect any improvement because we don't expect it. It can happen, and that's, you know, fortunate, but we never make any promises that that's going to improve.
Okay. Thank you.
Okay, Art?
Yes, can you hear me okay?
Yes.
Okay, in the past, our members of PNMD have had to go to Sacramento or Redwood City for surgery. As far as I know, they don't do any surgery here in Walnut Creek. Is that still the case? And
Yes.
if so, why?
Yeah. So this is for Kaiser because within Kaiser, our neurosurgeons are in Sacramento or Redwood City. We don't have neurosurgeons at every Kaiser facility. And I think the reason is that there's a lot of very specialized equipment that's used during these deep brain stimulation surgeries. And so our neurologists are all in those locations. That's how Kaiser system operates. And I think it's a matter of probably economy, is my guess. Having a neurosurgeon available at every single Kaiser hospital would probably not be, very economical. And there's not that many. You can imagine of all surgeries, very few are getting DBS. There's a lot of orthopedic surgeries, heart surgeries, other surgeries, but these are very specialized surgeries.
Thank you. Also, I had DBS about 20 years ago.
Okay.
Oh, I'm
Was
sorry,
was it at Kaiser?
15 years ago. No, it was at Stanford.
Okay.
I just wanted to compliment you on your presentation, as you described my experience very accurately.
Oh, good.
Thank you very much.
You're welcome.
Okay, Janice, you're
Yeah,
up.
I want to say thank you for the presentation too. We don't get very many people asking about it, but I think from a caregiver's point of view, there might be some considerations. But my question I have right now is what happens over time? In other words, say 5 years out after a person has had this procedure, do they require more or less of electricity to maintain their symptom control, or?
Right. That's a great question. So yeah, there may be some changes. People are usually pretty stable for the first several years. Once the program is optimized, I see people who've been on the same program, the same settings with the same current for, 4, 5, 7, 8 years. It's variable. Now, all of our brains shrink over time, actually. And so that means that there can be very slight shifting of the electrode with respect to the brain. So if things get worse over time, I might have a person come in and kind of repeat the interrogation where I look at each contact and make sure that we're still targeting the best contact and that things haven't shifted. But as I mentioned, unfortunately, this does not cure Parkinson's, and the disease does still progress. So it does get to the point where DBS, just like Cinemet, isn't really helping that much. But I have seen patients respond to DBS for 15 or maybe 20 years, like your colleague there.
Mm-hmm. Yeah. Would you ever consider having a patient replace electrodes as technology improves over time?
I have not seen that happen. So we definitely replace batteries. Batteries run down. Non-rechargeable battery lasts 3 to 5 years, and then it is replaced. The electrodes I've never seen them replaced unless there was a problem. For example, if they had an infection and the electrode needed to be explanted, the electrode may be replaced, but we have not replaced electrodes because of advancements in technology.
So if there's ever a wireless connection, you wouldn't, or I shouldn't say, absence of a wire, between the battery pack and the electrodes. Isn't there something like that in the pipeline?
There may be. What we have now is a wireless connection to the battery. So I can connect to somebody's battery through Bluetooth. It used to be that I had to put something around their neck and be connected by a wire to my programmer. But now I'm able to connect through Bluetooth with a lot of the systems. And I know that there is a plan that I could theoretically program somebody remotely, meaning that I could be in my office and they could be at home, like a video visit, and that I could actually make adjustments. That has not happened yet. In terms of wireless to the battery, that I don't know of that being on the horizon.
Okay.
I think that we still need a wire to deliver the power.
Okay, thank you.
Yazi, unmute yourself. Yazi062. Or you had your hand up. So if you unmute yourself, yeah, go ahead now.
You said in your lecture that 8 times a year you pick people. Does it stay with that same group or do you keep adding people? Like, would I be considered it for the 8 times that you do it, or once I'm not denied or whatever, not picked, would it be later I would have a chance to be picked to do the surgery?
So our group meets 8 times a year and looks at the candidates that have come along since the last meeting, basically. So once somebody is, once we say, yes, let's go ahead with the surgery, then the surgical team is working with them on scheduling, and they don't usually come back to be reviewed by our team. Occasionally, somebody will, several years down the road, want the second side implanted, and then we'll look at them again in our team. I don't know if that answers your question.
Well, I just was wondering if
Are you selected?
if I'm not selected, do I still get to stay in there and possibly have another chance of getting picked, or is it?
Most likely not, because it depends on why you weren't a candidate. But let's say that you had something else going on, like you needed a knee replacement before we did this. Then maybe you would come back, be reviewed again once that was taken care of. Or sometimes people have some other issue that needs to be dealt with. So we see they're reviewed and maybe they have, maybe they are drinking alcohol heavily, for example. So that would be a problem for surgery. So we may say, we want you to go and work on that. And if they're able to work on that, they might be coming back and being reviewed again for surgery. We've had a few patients who are extremely obese, like really significantly overweight, to the point where surgery was more risky. And we've said, I think if you can lose some weight, then we could consider surgery. So those are a few examples. But if somebody, for example, has cognitive decline, so they're already showing some signs of cognitive impairment, that generally does not get better over time. And so they would likely not become a candidate in the future.
Okay.
So how do you get?
Now we're almost at the end of our hour. Are there any last questions? Marjan, go ahead. You have to unmute yourself, Marjan.
Okay, thank you. I was just wondering, the gentleman who had the DBS 20 years ago, is he still benefiting from the effects of it?
Yes, I am.
Oh, okay.
Actually,
Wow.
it was less than 20 years ago now. I think it's about almost 12 years now.
Mm. Okay,
but I still
Thank-
derive some benefit from it.
okay. Thank
Okay,
you.
well, that about brings us to the end of our presentation.